After over 12,000 views and over 50 comments, I am extremely delighted to have Deborah Hewett back. In our first video, that was an amazing conversation. There was a lot of interest on YouTube and several questions in our live stream as well regarding what is a radiologic technologist and what you all do. So I'm very happy to have Deborah back, and she's going to give us an update. Just to give everyone a brief summary, she's a former flight attendant for 12 years or so who lived in Maui every weekend for about 8 years. And then you turned radiologic technologist.
Correct.
And not only were you a radiologic tech, RT, you were an instructor and you still teach.
I am still a clinical instructor.
And now you have taken a different role. So I want to kind of catch up with you and maybe answer some of the questions posed by a lot of the viewers on YouTube and also on Facebook. So welcome back.
Sure.
Thanks for
it's always good to see you, Dr. Lin. Yeah, I'm glad to be back.
So tell us, what is new in the world of radiologic technology training?
In the training, we're focusing more on the digital components now. Digital is now the gold standard. Back when I went to school in 05 to 07, we were still learning film. Although it wasn't used much, we were still, learning it, and it was still on the boards. And now that has been completely eliminated. There's a whole digital section on the boards. Other than that, most of the training is still the same. We're still required to do 1,800 clinical hours. Most of the coursework is still the same.
So when you say the board, you're talking about testing and be board certified in RT.
Correct. There's a federal agency, the ARRT, that governs our profession. You have to pass the boards with a 75 or better to become licensed. So you get a federal license and then you get a state license.
And that's how you can start, right? You start with basic RT and then you can go into all the subspecialties like advanced imaging like MRI, PET CT, and all that stuff.
MRI, CT, IR, mammography, nuke med, ultrasound. There's so many avenues you can take if you choose.
I know a lot of people tend to want to know what is the salary of an RT. And in the last video that we did, we said that it depends on where you work. But I think on average around 40, 45, something like that on average, median? I
would say you're looking at about 45 to start. And then depending on your years of experience and the certifications you add, I know X-ray techs who make 6 figures, but they're working in cath lab and IR, and they're doing quite a bit of call. So you can make as much as you want to make depending on what you add behind your name.
And call is a rapid way to burn out, but it does accelerate your income.
It's not for me. It's not for me.
Okay.
That much call is not for me.
You got it. So it's interesting. You said in cath lab, right? Can you tell the viewers a little bit more about what is involved as an RT in a cath lab?
You would take images during cath lab procedures, angioplasty. You image live. They inject dye into the coronary arteries, and then they fix it right there if they need a stent. So there's RTs, and then there's RNs working alongside the cardiologist.
There was a question in among the comments on YouTube that do RTs deal with needles?
We learn venipuncture in school. I'm not a big fan of needles. I'm not a fan of being poked with needles. I learned venipuncture and I did just fine. In our facility, we're not allowed, in general x-ray, we're not allowed to start IVs. But our CT techs do, our nuke med and MRI techs certainly do start IVs. So if that's something that's not for you, you want to kind of limit which areas you go into. But I would say, suck it up, get over it, and just do it. It's a great career. So I would not let that hold me back.
So let me go back a little bit. You said that board certification changed from film to digital.
Correct.
How was that transition for you? Because you started in film many years ago, and then now you had to learn digital. How was that transition as an instructor and as a tech?
Well, you learn it on the fly. When I started, digital was just becoming a thing, and we had some digital rooms. I've never worked with film. There was an intermediary step called computed radiography. So it was sort of in between film and digital. So there was phosphorus plates. You would capture the image on the plate and then put it in an image reader, and that would take the image off, clean the plate, and then you'd be able to use it again for another person. So when I started, that was the primary means, not film. And the digital was, oh my gosh, it was like a blessing when it came about. It makes my life so much easier. It captures the image in less than a second. So I don't have to go run my images anymore. I know instantly if they're good or not.
Oh yeah, because often you are at the bedside, you're actually taking the image, and then now in the past you have to actually run the film, develop it, and transfer it.
And there was nothing worse than shooting a hip in PACU, having to run all the way downstairs then say, oh my God, it's not good. I have to go all the way back up and shoot it again. So digital is just wonderful. It's made us so much more efficient. It's actually brought the amount of radiation we use down. It uses less radiation, and we're able to work so much faster and so much better. And patients are always amazed when we show up in the room and we have, the portable equipment. We're just just going to snap it right here. Okay, it's good. Bye. And they're like, what? It's done already? Yeah, you're done. So it's just amazing to work in digital.
There's a lot of interest among people who are just thinking about getting into becoming a radiologic technologist. And one of the questions was, what does one need to learn before applying to an RT school? Because it's not very easy, I guess. It's not easy.
It's very competitive. We have 3 schools here locally. For them, 2 of the schools require prerequisites. So
what are some of those prerequisites?
Some of those would be medical terminology, anatomy and physiology, advanced algebra, English, communications. If you're not computer literate, you're not going to make it in X-ray.
Because it's all digital now.
It's very technical field. Yeah. And so you can get some of those things done in advance, and then you would apply for the program. Some of them are on a point system, so you go by your pre-existing grades. How good are your grades? Some of them require interview. How well do you it's like a job interview.
To get into the school? Yikes. I didn't realize it was that competitive.
They may have anywhere from 200 to 300 applicants, and they'll weed that down to 20 or 30 people. So they'll literally take maybe the top 10%. It's very competitive. I know people that have tried multiple years to get in, and finally maybe on the 4th year, they get into the program. The schools are doing a good job at limiting how many people they graduate. It's still a high need field. All of my grads are getting hired up right away. Some of them still.
I mean, there's no change from 2 years ago.
It's just going to escalate over the next 10 years. There's going to be a shortage of all healthcare workers, and we're no exception. So it is a good time to come out. Some of my grads have multiple jobs already.
Job offers.
Yeah, they're working multiple places, more than one. Hospital,
That's great.
Yeah.
So speaking of hospital, what is the typical schedule for a hospital technologist?
It depends on what kind of tech you are. I'm a full-time employee. I do 40 hours a week. We have part-timers who do only 20, and then we hire per diems. And per diems can do up to 40 hours a week, just fill in the blanks where we need help, sick leave, maternity leave, vacations.
Kind of fill in.
So
it varies. It seems like it's part-time, per diem, all the way up to full-time.
Right. I have steady hours. I love my schedule. I'm 6:30 to 3. I think I have the best hours. I get out and I still have my whole day left.
That's true.
But some of our per diems, they're all over the place. So they might work 3rd shift. They might work 1st shift. They might be 12 hours here, 8 hours there. If you want, there's a lot of work to pick up. So when I was per diem for my first year, I was working 50, 60 hours a week.
Wow.
Because I worked for more than one company. So I was able to, if you really want the hours, they're there.
Wow. It sounds like, it's really in demand, sounds like.
It is.
Yeah.
And it has to be staffed 24/7 at the hospital. We always have to have somebody there. It's not something like you can go away.
Because the ER, there's always a demand in the ER.
ICU, middle of the night, they need things, and they need it stat, and somebody has to be there to do that.
And that'll be you.
Well, that won't be overnight. I won't be on
overnight. But it'll be an RT.
Somebody will be there to take those pictures no matter what.
Yep, definitely. Yeah, and one of the questions on YouTube was, is there online training to become an RT?
I got that question as well on Facebook. Someone private messaged me and asked me that. And at first I thought that was kind of silly. How could you do this online? But then I thought about it, and you can do some of the classroom portion online. Some of your prerequisites, make sure that they do transfer into your x-ray program. But you probably could do some of those online. But then when you get to your clinical rotations, that cannot be done virtually. You have to work with live patients. You have to learn from experienced x-ray techs in the clinical setting. There's no way you could do those hours online. So maybe the classroom portion, but not the clinical rotation.
Yeah, so the 1,800 hours that you have to do with patients, I mean, you can't do that virtually.
You can't fake that. You have to really deal with patients. And I've seen some people go into the field where they were so sure they wanted it, and then they start to work with patients and they're uncomfortable working with people, or uncomfortable touching people, or they don't have good people skills. And they're like, well, I thought this was a technical field. I didn't think I was going to have to do this.
Yeah, because as an RT, you are at the bedside, and sometimes you have to move limbs if they're injured, the part that you want to x-ray, and then you have to put things behind them to capture the image and all that stuff.
There's a lot of patient care involved, and you have to be good at that. And there's no way that you could learn that online. You just have to do it. For real, in the hospital or in the imaging center. Yeah,
and then at our last interview, you said that you kind of have to be pretty strong in pushing these X-ray units sometimes.
Yes,
especially the ones in the operating room.
Right. I schlep around 1,000 pounds of C-arm during the day, but also I can lift up to a 300-pound patient by myself.
I hope not.
I know. I try not to, but I can assist with that. I'm pretty in the ICU. If they're out and they can't help you, you have to figure out how to get that board under them.
That is true.
It might be dead weight, so you have to be smart about it.
I'm gonna digress a little bit. Mm-hmm. We are in the middle of the beginning. Actually, we're at the beginning of the coronavirus, COVID-19 outbreak, and we're so fixated on this virus, this novel virus. When heart disease kills 647,000 a year, we know that is going to happen every single year. We know obesity is one of the big health determinants of health, and yet we're not freaking out over that versus COVID-19. But anyway, I digress.
That's so true.
I digress. So let's talk about your new role. I mean, you're no longer an RT, just an RT. You are now a lead RT. So tell us a little bit more about that.
So I was formerly the primary OR X-ray tech, and I was really happy with that. I was very content, but after a while it started getting a little boring. And I thought,
you want more challenges.
I need a challenge, and I decided to go back to school to get a master's in healthcare administration. I just graduated in October, and I've been really lucky because I'm already using that. Position opened up in January, and I was able to step into my first leadership role. So I'm now the lead tech. So I don't get to go to surgery as much anymore, but it's really fun. I'm problem solving all day long. I have to expedite our workflow, decide who goes where, who does what, and that includes myself. I'm still a working tech, so I'm still taking x-rays. Have to make sure we have enough resources, enough people, enough supplies to do what we have to do. Have to make sure all of our equipment is working, because x-ray equipment is kind of ornery,
especially
it's a little touchy.
Especially when you transport it over the hospital.
Right. So I'm like a little bit like the mom of the department. I'm also a little bit of a mechanic. I'm always fixing things.
No way.
Yeah, I hear my name about 1,000 times a day. Deb.
Yeah,
Deb.
You're kind of you become the go-to person whenever there's a problem.
Right.
Either it sounds like you're doing not only the radiologic technologist role, you are also kind of doing resource management and also resources as far as hardware and also personnel.
Correct. All of that. And then at the same time shooting x-rays and answering the phone. And I get probably 50, 60 phone calls a day from patients, from doctors, from other departments. So it's just kind of managing that, knowing what to say, what to do in every situation, and prioritizing our exams. We might have 10 exams to do at any given time, maybe more, sometimes way more than that. And I have to decide what comes first, what comes second, what comes third. And you always have doctors calling you. They want their person next.
Of course.
And you have to decide, well, is that really,
There's something,
right.
You have to prioritize
and so,
the calls.
I have to make sure that everything gets done in a timely manner, but also in the correct order.
Yeah.
And that's constantly changing. So as I'm trying to manage those 10 exams, more stuff is coming off the printer. Some of that might be more important than the 10 things that we're already doing. So then it's like I have to kind of switch gears. Okay, now we're doing this instead.
So what are some of the most common patient questions, that the calls that you get?
From patients, it's primarily they want their reports, they want their CDs made, and I'm not really the right person for that, so I transfer them on to the right person. Sometimes they have questions about an exam that's coming up. We do fluoroscopy, so upper GIs, VCUGs, lumbar punctures. Some of those are very scary things for a patient, and they have a lot of anxiety before they would come in. So they call me to give them a detailed explanation of what's about to happen to them so that they're a little bit more comforted before they come in. So I do that a lot too.
Sure. For our office procedures, we try to educate the patients beforehand a lot so that they know what to expect, including handouts. I wonder, what is your protocol at your place of employment?
I don't know that we have handouts. I think a lot of the doctors don't prepare their patients well. They say, oh, you're going to go for this lumbar puncture. And it sounds like a terrible thing, but they don't explain it.
Yeah.
So I think within our hospital, I think we have handouts, and I think we have education on the TV for inpatients. I just don't know that people are using it.
Got it. I think a lot of the orders come from the physicians, and then the physicians are not telling the patients what to expect.
Correct.
And then there's a lag in communication. So maybe that's why you're getting some of the phone calls.
There's that. And also, like within the hospital, we allow patients coming down for a procedure that they were never told they were having. So there's some confusion there. So inpatient. So who ordered this and why? I get that question a lot. And I always give them the option, if you're not comfortable, if you want to hold off till you've talked to your physician for a better explanation, I'm totally cool with that too. I'm not going to force anybody to do anything they don't want.
Yeah, it sounds like communication is a big issue.
Communication is a big issue. Yeah.
Other than physicians asking you to expedite their study first, what are some of the other questions or the phone calls coming from physicians?
A lot of times they want to speak to a radiologist about something a radiologist just read. Either they agree or disagree with it, or they want more information. That's very common. A lot of times they want me to move something up in priority that's already been taken. It's sitting on the work list, and like, can you make this stat move it up? So I get that frequently, mostly from the ER, because every exam we shoot in the ER, it gets two sets of eyes. First, the ER doctor looks at it, and then if he's not sure about what he's seeing, he wants the radiologist to look at it right away because they want to diagnose that person immediately. So I move that up in priority. I take a lot of those phone calls every day.
Wow. Okay. So that's a lot of phone calls.
Yes.
As far as management, now you're the lead RT, or you're the RT lead. What is next for someone with your credentials and extra training?
Well, I would like to move up the food chain. The next step would be supervisor, manager, director. But also I'm thinking outside the box, and maybe I won't stay in radiology. I would love to stay with my company, but possibly in a different role. Very interested in quality management and quality improvements. I'm also interested in health promotion. It's kind of a growing field, and in helping people make better choices, helping patients take more accountability for their own health, so maybe they don't use as much healthcare.
Health promotion.
But we currently don't have a division of that within my company, but that's something I'm really intrigued by, and I would love to do that.
Well, definitely health promotion is super important. I mean, we just talked about obesity and cardiovascular health.
Exactly.
But it's definitely not as sexy as COVID-19 or coronavirus
or
SARS-CoV-2.
Not sexy. Like telling people that they have to eat better, exercise more. A lot of it is disease management, but it could apply to anybody, really. For the future, we might have to think about making patients take more responsibility for themselves.
I think that should be happening right now.
It should be.
Yeah.
It should be.
But it's something that is hard to do.
It's very hard. Nobody wants to be told, everybody. So we have our rights to live the way we want. If I want to smoke, I'm going to smoke. And if I want to not work out, that's my prerogative.
That is true. It's hard to balance the two aspects, right?
It is.
But then if those who are not taking care of themselves, they end up using the system a lot more and burdening the system.
Right. I've heard a statistic once. I'm not sure if this is a very small percentage of Americans are using 90%.
Other healthcare
of
resources.
the healthcare resources. Yep. And it's, it's something that we have to look at is why and what can we do to change that?
Well, I think those are noble goals.
Mm-hmm.
Awesome. So what else besides management are you looking at doing?
I'm still a clinical instructor. I'm actually very happy with my current role. I've just stepped into it about a month or two ago, so I'm still
since January.
Yeah, I'm still focusing on getting better at what I'm currently doing. I'm not looking at making any other moves anytime soon.
Awesome.
But I'm very grateful for my employer. They actually paid for my degree. So
that's something to look into as folks get into different roles.
If you choose the right organization that has tuition reimbursement, you can go a lot further. So you can become an RT, or even we have people who are just transporters right now in our hospital who have plans to go to nursing school or become an RT or respiratory therapist. And if you've established yourself as a full-time employee for a year, you can get this additional training for free if you play your cards right.
Yeah. So as far as place of employment, it's not just the dollars that matter. You got to look long term, depending on what you want to do. And I think it's a great idea to start as a transporter or just getting oneself into the healthcare system to make sure that this is truly what you want to do.
If you're a 20, 21-year-old and you don't know what you want to do in healthcare, becoming a transporter or working in the cafeteria, for instance, it might be a great way to start, and then start asking questions around the building. What do you want to be?
I spent a lot of hours as a volunteer, believe it or not.
Did you?
Before med school, yeah. So much so that I ended up getting a lot of scholarship and a lot of awards before getting into medical school. And it's a great experience. I learned a lot of the medical terminology, but believe it or not, back in the day where you have to physically transport the surgery schedule to every floor, every nurse's station. That was part of my job.
Oh, that's all computerized now.
Yeah, I know. And there was no real big issues about HIPAA because there was, I guess, but I was able to read the operations. So that's how I learned, what is that operation? So I would read the operations that are scheduled, and then I would learn about them. So that was pretty cool.
Oh my gosh, that's fantastic.
It's definitely useful to get into the field even in the periphery. I mean, I did it for free, so definitely look into it and get involved for anyone who's interested in getting into the healthcare field. Just get yourself into the field.
That's still a thing. We have, I think, over 400 volunteers, mostly older folks, between our two hospitals, but then also in the summer, the volunteers. And it's a great way for them to see if they want to go into healthcare. If they're not comfortable around patients, then maybe it's not for them.
That's true. What is the typical attrition for someone after they get into an RT training program? Do you see a lot of people dropping out?
Typically, I don't. With the three schools that we have, if they start 30 X-ray students, they might graduate 26. There's things that happen, life things. Yeah. Sometimes financial, maybe it's, family situation. We do have people that drop out, and then you have some people that the program doesn't suit them, or they start failing. Their grades are not good, and if that's the case, then, that probably is not the right career for them if they're failing.
That is true. Have you noticed have you been able to tell from just at the very beginning of you getting that student, which ones are more likely to fail, and what are some of the characteristics?
There's certain behaviors we look for, and you don't have to be technically skilled right away. That part I can teach. I can't teach empathy. I can't teach work ethic. If you don't come in with the right attitude, a positive attitude, and then the willingness to accept constructive criticism. I try to give positive reinforcement, but also I have to have some talks with them about, this is what you did right, but also this is where you could do better. And some of them just kind of, they don't want to hear it. They don't want to hear it. They want to just hear that they're great all the time, and everyone. And I know that those ones are not going to do well. I don't think I'd want a coworker who's not open to listening and sharing, and I have a lot of knowledge, and I'm trying to help you. And if you're going to shut off your ears, then Well,
I think part of the problem is it's the mentality of 10th place trophies, right?
Yes,
so everybody's getting trophies, everybody's getting the rewards. Hey, you did great, even though not really, right? They're not used to
Right.
hearing criticism. So even when it's constructive, they're averse to it. So that's really
Right.
unfortunate.
I'm really lucky. I think the 3 schools that we accept at my hospital, they've given us fabulous students. I kind of say we get the pick of the litter, but as nice as I am, I have thrown 3 students out over the 11 years I've been a clinical instructor. And
Yikes.
all 3 of them for the same reason, patient safety. You can't come into our facility and do things that may jeopardize our patients. If you're not using common sense, don't come here.
Well, common sense is
You
not
know,
very common. So
no,
what were some of the things that they were doing?
Standing up a person who is a high fall risk
Got
to
it.
make the exam easier for the student.
For the RT.
Yes, instead of thinking about this is not the best thing for the patient. I can do almost everything sitting or laying down that I can do standing up. I don't
For the
need-
patient.
For the patient.
Yeah.
I don't need them to stand
Yeah.
for most things. So if they're in the wheelchair and I need to do this whole thing in the wheelchair, which is best for them,
But it's
That's
more work for the RT.
more work for the RT. So a lot of the students are like, I'm going to make this easy on myself.
Got it.
I had a guy who stood up somebody with a broken leg to make the chest x-ray easier for him. And I'm like, you're out, buddy.
That is
You're out.
that is insane.
we don't do this.
Well, like you said, it's
Yeah.
empathy. A lot of people lack
Right.
that empathy. And you brought up some great points regarding hiring on attitude and not so
Mhm.
much aptitude. You can
Right.
give the person aptitude and train the person, but you can't. It's hard to change someone's attitude.
Correct. And even when they graduate, there may be a lot they still don't know. So we always say your first year as an x-ray tech is your last year as a student. And we're there in a supportive role to help support the new grads that come on per diem. I always try to help them out and mentor them if they're open to it. But yeah, if you have a bad attitude and you just think, no, I know everything already, that's not a good way to come in.
I think that goes for every profession. I'm still
True.
learning myself after so many years completing residency, and everything changes. I mean, just look at the RT, our RT world. You went from film to digital, and who knows what's going to happen next beyond MR, CT,
Right.
PET, nuke med, and stuff like that.
Right. I have no idea what's going to happen next. And maybe thermal for all we know. There's some
What are you hearing about thermal?
There's some thermal breast imaging now. It's not the gold standard, but they're starting to experiment with different forms of imaging than we've ever had before. So who knows 50 years from now?
Thermal
What
will
will
be,
we
thermal will be pretty exciting.
It would be exciting.
All right. Well, anything else that you want to share with our audience?
No, I hope I answered all the questions and
And I'm sure this will raise even more questions. And,
probably will.
And
Yeah.
I put the link to your Facebook account in the video description. So if anybody's interested, they can click on that and maybe DM you.
Yeah.
And I think that's pretty much it. Yeah. So we'll answer more questions for all of you. Please leave them in the comments. If you have any questions for Deborah, hit her up on the DM. Thank you so much for watching. Bye-bye.